The Physicians Foundation has talked about the fact that this is a watershed year, 2013, for healthcare in the United States. Compensation for physicians is always a tough topic and one that has had almost nothing but bad news in the last year or two. So we're talking about Compensation 2013, State of the Union, and we're with Patrick J. White, president of MedAxiom in Michigan. And you just presented this discussion. Where are we with compensation? What is the State of the Union other than disarray?
Well, physician compensation is dependent upon many variables. And some of those variables are controllable and some are not controllable. And so the focus is, let's look back and find out what affected compensation in 2011, 2012, and what's likely to affect compensation in 2013. So a number of issues come to mind. And one of the probably most troubling aspects of cardiology practice is these things I have no control over. Can't even estimate what the impact is going to be. So as we look to the future, 2013, we know one thing's, we're confident that things are going to change. We have to change. We have an unsustainable healthcare delivery system now. So we know that we're going to make a transition from fee-for-service care to population-based payment. And that's going to take a number of years, but we've got to start transitioning to that. We have to learn how to manage our patients more efficiently, and the tough aspect of that is I'm still going to get paid in a fee-for-service world for some time. So there are a lot of issues that come to mind that are really not totally under our control, and part of it is the terrible financial situation the United States is in. So as a result of that, the fiscal cliff, et cetera, a lot of decisions are made without looking at them carefully, without studying those, without using data, last-minute decisions that will affect reimbursement and therefore physician compensation. But when you look at the history of the last couple of years, physicians have done well. We've actually improved productivity. We've learned how to be more efficient. We've learned how to use mid-level practitioners to help with some of the care that's provided by physicians. So we're doing much better than one might otherwise expect. The big area of improvement is going to be the transition to population-based care. We're going to have to learn how to keep patients out of the hospital, how to deliver care more efficiently. And there's a lot of coordination that has to take place in order to make that happen. So when you think about heart failure is the common example that's used, there are so many other people involved in caring for heart failure patients. We've got to learn how to get all of those folks together and design a plan for caring for the patient to keep them out of the hospital, keep them healthier. Right now we're not paid to do that, and that's part of the dilemma. We have to learn how to start caring for those patients even though we're not going to get paid for it, so that it keeps patients out of the hospital.
You know, that survey that I talked about at the very beginning where Physicians Foundation, one of the problems that physicians point to for 2013 was the rising administrative burdens. And, was PQRS was providing benefits, bonuses for certain quality metrics. Not a lot of doctors have taken advantage of that. Now we're getting to the point where it's 0.5% or 0.5% for a bonus, and that's soon going to be just the opposite. It's going to start costing you money. Why is it so slow for doctors to get used to these kinds of quality measures and the reporting of it? Is it the frustration? Is it just getting the things in place? What is it?
Well, there are several programs. You mentioned PQRS, there's e-prescribing, meaningful use, and value-based purchasing. Those are the four big administrative programs. Cost money. For instance, meaningful use, I've got to buy an electronic health record. I've got to implement that, and then I've got to learn how to use it meaningfully. I have to attest to that, and that all costs money, and there's some risk involved. But initially, all of those programs were set up so they were voluntary, and there was an incentive that was provided to get people involved. But they all transitioned to mandatory with a penalty if you don't participate. But they're bureaucratic in some respects, necessary in other respects. We have to have electronic health records. We've got to be able to collect data into definite fields so that we can report data, so that we can prove using clinical data that we're providing good care. Right now, many of the programs that currently evaluate physicians and whether or not they're providing high-quality, low-cost care are based upon claims data, not clinical data. So we need to collect that clinical data so that we can correctly and accurately report our performance. But those programs are expensive, but you have to do it. And I think if you look at our membership, cardiology especially is probably well beyond most other specialists in adopting these programs.
Which is really good. It was, I think, the radiologists where it was less than 1 in 5 at the moment, which is, it's really low. I guess the last thing with MedAxiom and MedAxiom Consulting, you deal with doctors across the United States. In terms of compensation, what works? What a well-compensated group or practice or individual, how do they differ from those who are having compensation problems?
There are so many variables that go into that it's really difficult to say there's one model that works better than any other. But as I mentioned in my talk, the groups that have their front doors wide open, see lots of new patients and office consults where there are no barriers to getting an appointment, physicians that are communicating well with their referring physicians, they're managing their office well, they're managing their no-shows and cancellations. Those are the groups that are seeing a lot of new patients. That's really what drives the practice. That's what drives the machine. Those folks tend to do better than others. But obviously managing your overhead intelligently, collecting on what you bill for. You can bill for something, but if you don't collect all of the money, you don't do very well. Negotiating good contracts with payers. There's a tremendous amount of variability there in how well people get paid around the country for non-Medicare business. There are so many variables that take place. One of our more productive groups once shared with everyone else in the membership that the number of staff per physician was extremely high. And the result of that, though, was that the physicians were either in the evaluation or the treatment mode at all times, never in clerical, never in administrative. Kept the physicians doing what only physicians should be doing. And that was one of the reasons for their success. I think it takes a certain kind of physician that doesn't want to get involved in some aspects of clerical and administrative work. But that was a good example, and I think there are other examples of people that have enacted a broader scope of work that do vein therapy and provide other services that can surely help the bottom line.
Well, thank you, and thank you to MedAxiom, because you're one of the sponsors of the Cardiovascular Summit. We probably wouldn't be here in Las Vegas talking about the business end of cardiology if it weren't for MedAxiom. So thank you very much for CardioSource World News. I'm Rick McGuire.